Hello, everybody. Welcome back. Hope you managed to get a coffee and a bit of a break there. We're now going on to our section on neurology, and I'm pleased to introduce you to Zani Wynn from Imperial College Healthcare NHS Trust. And hi, Zani. And hi, how you doing? And Zani's going to take us through a talk on amyloid imaging in the investigation of dementia. So, Zani, you should get a show your screen opportunity.
Yeah, I'll show my screen. Let's try that. If that works.
Yeah, that's good.
Oh, fantastic. Okay, good. Okay, works.
Yeah.
Thank you, Steve Helena, for invitation. These events have it's really, really good talks so far, I think. So I'm the head of nuclear medicine at Imperial. I'm going to talk about amyloid brain PET. I'm just going to look at my clock. So we've got about 20 minutes. I'll keep it under 20 minutes. So I'll do sort of, pretty much a brief overview in the time we've got, really. Let's put a little stopwatch on. Okay, so what I'll go over is the first part's going to be about why we actually do amyloid PET studies. I know it's not very widespread within the UK at the moment. Only limited to very few centres, but it is a very important part of the dementia sort of, investigation pathway, which I'll show you. But I'll talk very briefly about how we perform amyloid PETs. And then in the second half, I'll discuss the sort of papers that we've written. And I think we've got the good author in the audience as well, looking at our experience at Imperial, clinically, and also looking at quantification software as well. And finally, just talk about the clinical impacts of amyloid PET reads. So, we get this asked a lot by clinicians and everybody, to be honest, why do you bother doing amyloid PET scans, and it's not been sort of formally authorized by NICE at the moment, but as you'll see at the end of this talk, and there's definitely enough data out there. So why do we need a amyloid class within the brain to diagnose Alzheimer's? Basically, to diagnose Alzheimer's, you need two findings. You need a clinical finding. So the clinician looks at the patient, speaks to the patients, and they have a suspicion that the patient's got dementia of the Alzheimer's type. But you need a second confirmation, and that is a neuropathological confirmation. So you need to prove that that patient who you think got Alzheimer's dementia has neuropathological evidence of amyloid plaques. And that can be gleaned in several ways. But so basically, you need two things to diagnose Alzheimer's disease properly. That's important because amyloid plaque buildup within the brain can precede clinical symptoms by over 10 years. So if you look at this chart, it's a really important chart in terms of sort of Alzheimer's progression. This is by Professor Jack from the USA. It shows here you've got a pre-symptomatic phase, which is going long years, up to 10 years or more. And then clinically, you get into the early mild cognitive impairment phase. Then you get the late mild cognitive impairment phase, and this phase precedes full-blown dementia. In the mild cognitive impairment phase, you might get very, very sort of subtle symptoms, maybe to do with language, to do with cognition, but you're still functioning. And you're still going to work, and paying your taxes and so on. And this stage is very important. And once you get into the full-blown dementia phase, then it's pretty much irreversible. So the timeline may accelerate for others. So you'll have to stop working. This will affect your mortgages, your insurances, and so on. So this is quite significant. So in the overall scheme of things, what we're looking to do is to diagnose patients for early, so which may be within the sort of MCI phase or even earlier, in order to sort of reduce the progression or the pace of disease and keep everybody functioning. The endpoint is getting a disease-modifying drugs. There's hundreds of millions of dollars and pounds invested in it. Almost all the studies have shown that the drugs do work, as in they do clear amyloid plaque from the brain. But what they haven't, all the trials haven't quite proved is, has that made a difference to disease progression? There are a couple of drugs at the moment. One is from Biogen, who's going towards FDA approval as we speak, and there's another one from Eli Lilly, which managed to get some significant results from their drugs, and just to show that there is improved clinical improvement or delaying of clinical deterioration with their drugs. So that's going through at the moment. So when that happens, when those drugs get approved, then the whole floodgates will open in terms of amyloid PET imaging. And other things that we need to, it's really important that we need to diagnose the patients accurately, and we need to treat amyloid PET, Alzheimer's disease as a disease, like cancer. So if in dementia, a lot of patients are misdiagnosed. Up to 20% of patients were diagnosed with AD and found to be misdiagnosed on autopsy, or people are underdiagnosed, or there's a delay in diagnosis. If this happened in cancer, it would be absolutely unforgivable. And I think dementia should be seen in that light, especially when expensive drugs are going to be in the pipeline. So in terms of proving if the patient's got amyloid parts in the brain, if you use a PET scan, obviously it's very non-invasive. The other alternative is lumbar puncture, which has uncommon but significant side effects, bleeding, pain, postural headaches, and possibly infection, meningitis. Also, what you find that going straight to amyloid PET reduces the other investigations, CT, MRs, neuropsychological, psychometric testing, which actually saves money for the NHS. And why do we need to diagnose amyloid in the brain? So what happens is, if you do have amyloid positive plaques within the brain, then your chances, and you've got sort of mild cognitive impairments, mild symptoms, your chances of converting fully to Alzheimer's disease is much, much greater if you have a negative amyloid negative patient. One of the early studies, this is a smaller study, but it's one of the early ones, shows that people with mild cognitive impairments, they had a amyloid PET brain scan, and those with a positive scan, almost 2/3 converted to Alzheimer's disease. Those with a negative scan, none of them followed up, and none of them converted. But obviously, it's never going to be zero, but pretty much it tells you the different course of the disease. If you have a positive amyloid scan, you will convert to Alzheimer's disease, and the clinical symptoms will inexorably worsen over time, pretty rapidly. If you have a negative scan and you still got symptoms, which is not sort of classically Alzheimer's by pathology alone, with a patient like this, your disease progression will be much, much, much slower. So when is amyloid PET indicated? Are there any rules that we use before we're choosing patients? And yes, there are. And there are these pretty much global appropriate use criteria, which was first developed within the S&M in the US and adopted by the Royal College of Physicians and the Royal College of Radiologists. So we can use amyloid PET scanning if the Alzheimer's dementia is a possible diagnosis, but still uncertain after comprehensive clinical evaluation and conventional workup, or where if you think the absence or presence of amyloid PET is expected to increase your diagnostic certainty. We're not so currently we're concentrating on young patients with rapid onset dementias, which is unusual, atypical features, and so on as well. So there are very specific ways, but it's still an expensive scan. It's quite hard to get hold of, so we use it quite sparingly. You definitely aren't allowed to use it if for like medical non-medical reasons, like a Theo walks through the door and just as a pre-employment type screening, or whether whether you're sure that the patient's got AD but wants to check anyway. So we can't use it willy-nilly. We did do a little schema, which is published in PJR a couple of years back. If you look under that, there's a little schema of how to diagnose or investigate dementias using PET and DAT and amyloid PET. So how do we perform amyloid PETs? In about 7 years ago, or a bit less, we did have the choice of three tracers, and during that time, we lost flabetavir, which was the first tracer available in 2013, and we used it first at Imperial, and then they invested a lot of money, and then they didn't get it back, and they decided to pull out. Flutamimab, Vizamyl never really took off, and now we only have Neurosect available. In terms of Neurosect versus Amyvid, basically they both work equally as well. Neurosect takes a 20-minute scan, Amyvid takes a 10-minute scan, not a huge difference. The way we read the scans is quite different. To get a positive scan on the Neurosect read, you only need one region within the brain to be abnormal, where Amyvid required 2 regions to be abnormal. And this is how you read Neurosect. This is the abnormal scan at the bottom and the normal scan at the top. So this is a binary read. You either say negative or positive. Positive scan is like a blancmange. You lose the grey white differentiation everywhere. With a negative scan, you still see the little nice little fronds and visible grey white differentiation. So this is a negative scan. This is how you read Amyvid on a sort of black and white. And there's a negative amyloid scan. And if you reverse the grayscale, that looks like a Neurosect scan, basically. And that's being sort of radiologists. We published sort of classical signs of a negative scan, like a branching tree, and also a classical signs of a positive scan, which whether you get uptake throughout the brain parenchyma, cerebrum, so you can't see the grey white differentiation. If you look at that one as a coronal setting, it looks a bit like a sort of a tree in bloom, so sort of spring blooming tree. Now, obviously, these scans are very important to get the patient nice and still. And this is what happened to one of our patients. This doesn't happen too frequently, actually. Trying to jump off the bed there. So that wasn't a very good scan. Right, so coming on to quantification, these are visual reads. How can quantification help or not? Does it help or not? So we looked at this a couple of years back. I think Daniel's in the audience. We looked at Amyvid scans, and we found that actually within the positive and negative scans, there were actually subtypes or differences within each scan. So most of the scans, probably about 80 to 90%, were called type A, nice, easy to read, but you have about 10% or 15% of scans which weren't, clear cut. We call them non-type A scan. So what we did here was we compared Hermes BRAS software versus the clinical report. The clinical report was basically double read, and see if it correlated. I'm not saying which is right, so so we just literally compared clinical reports, the BRAS report, and also got 3 other readers to look at the scans again and compare that against the clinical reports. When you compare all types of scans, whether it's a type A, typical scan, nice, usually easy to read, to and the non-type A scan, you've got kappa score of 0.6 versus clinical report versus Hermes BRAS. When you look at the type A typical scan, there's much better correlation between the clinical report and BRAS. But if you look at the atypical non-type A scan, the atypical scan, more difficult scans to read, there was quite a poor correlation between clinical reports and BRAS software. So other interesting thing was when you looked at compared brass to the 3 separate clinical reads. When you look at the difficult study, we have 3 reviewers looking at it again, and they found out that the kappa scores were quite poor between them as well. So there is a segment of these scans which can be difficult to read. But most of the scans, say 80% will be straightforward to read, and everybody will agree. Different readers will agree. Quantification will agree as well. So what we need to do is we need to recognize when you actually see the scan, if it's a typical one, a non-typical one. The non-typical one, be very wary of using qualification, because then you need to get a second pair of eyes on it. Use quantification as well, but we need to sort of, measure all the results very carefully, discuss an MDT, look at MR and so on as well. I think quantification will be quite useful if you are a single-handed practice or dual-handed practice, and that gives you, it's a bit like DAT quant, it will give you increased confidence in your reads. Now, what is the clinical impact of these scans? And the first scan was actually, I think David Cameron, I think Fowler must have been leaked by Eli Lilly, who was the tracer manufacturer. And he was there, back in 2013, in December, saying his first free scan is going to be at Imperial. You've got Jeremy Hunt there, one of our favorite people, saying, being very realistic, saying he's going to pay for it. And since then, we've scanned over, we've scanned about 700 patients now. We looked at the first 100 patients to see, is there any benefits, clinical utility of these scans. And we did 100 patients, and half are positive and half are negative, which is, I think, really good. So, which means that we actually identify those patients quite well. And we found that it changed diagnosis in over 30% of patients, and also changed management in just under half of the patients. So these scans were, to us, very, very useful. It also reduced the overall burden of further investigation, so reduced the number of MRI scans that you would have to do without amyloid PET. And we really narrowed our focus on difficult patients. We got a tertiary center, dementia referral center, so we went for younger patients, atypical presentation where everybody's really struggling on the diagnosis, and we found it really, really useful. Now, while we were doing that, there was a huge study in the US, it was called the IDEA study, and they were looking to determine if amyloid PET scan also, made any changes in management or in diagnosis in mild cognitive impairment and dementia. So they, everybody had to undergo the appropriate use criteria, as we discussed before. But they enrolled over 16,000 patients over just under 2 years, hundreds of sites, and had almost 1,000 dementia specialists involved. So a really, really good study. They want to see if there's any change in rate of use pre and post PET of Alzheimer's drug therapies, counseling, and so on. And the results were quite compelling. So about 11,000 of those patients completed the studies. Amyloid PET was positive in about half of the MCI patients, and about 70%, 2/3 of the dementia patients. And they found that there was a huge change in management, about 2/3 of the MCI patients, and also 2/3 of dementia patients. And there was change in diagnosis from Alzheimer's to non-Alzheimer's in about a quarter of patients, and from non-Alzheimer's to Alzheimer's in about 1 in 10 of these patients. So, quite significant changes. They also found reduction in neuropsychological testing, and also CSF testing, which reduce sort of pain and time for the patient and cost for the patients as well. So they found that there was amyloid PET scan definitely influenced management in these patients, and changed diagnosis and also changed management. So coming to the end, evidence is pretty overwhelming, especially with the American IDEA studies. So I think it's about time that the British authorities NICE approve amyloid PET. It's making a huge difference, definitely in the Imperial practice, dementia practice at Imperial, and we're highly selective of which patients to use, and we do use these sparingly. So I would say that, you know, if there's anybody here from NHSE, that, you know, that clinicians at MDTs can use this, you know, quite an expensive resource quite sparingly, and, you know, we take our time, you know, selecting our patients within the MDT. Right, thank you very much.
That's great. Thank you very much there, Zani, for a really illuminating talk. And Helena, I don't know, I don't see any questions from the audience. I don't know if there are any, anyone does have any questions.
No, I can't see any. I think Zani's talk leads nicely onto Johan's research work, so I'm going to head straight on to Johan now, I think.
Thanks once again, Zani. And yeah, so Johan Lilia will be now talking about amyloid brain quantitation. So it is very relevant to the previous talk.
Oh, sorry, there is one more question. Sorry, Johan. Zani, Charlotte asks, how are you funding the studies at Charlotte Fowler?
Charlotte, that's a top secret. I can't tell you. Actually, you know, our specialist commissioner was very clever and active, you know, when we first started this. So literally, I think she went direct to NHSE, and we agreed sort of 100 scan limit to NHSE London. Yeah, so basically, I think you'll have a specialist commissioner within Role 3 who'll have to directly engage NHSE London and come up with a deal, basically.
Great, thank you. Okay, Johan, go ahead.
All right, thank you very much, and thank you, Zani, for a very nice presentation. I have deleted half my slides here during your presentation. So I'm going to talk about quantification, and specifically I'm going to talk about the A-beta accumulation index, which is a novel quantification method for amyloid PET, and it's targeting clinical routine as well as large-scale clinical trials. And I want to start the presentation with a quote I had in an email from Nema Patel, a colleague of yours. For the 41 fluidometamol subs, we sent 100% agreement with the clinical report. That's the kind of emails you appreciate when you work in quantification and development. So thank you very much for those kind words. Alzheimer's disease is the leading cause of dementia. You already all know that 70% of all the cases is irreversible progressive neurodegenerative disease. And the physiological hallmark is extracellular depositions of A-beta amyloid or amyloid plaques. And it interrupts the neuron-to-neuron communication, leading to impaired brain function. So they can't communicate any longer. And that leads into intracellular neurofibrillary tangles of hyperphosphorylated tau proteins. Tau is another PET tracer coming up here, which prevents the transport of nutrients and other important substances. And ultimately, it leads to apoptosis. So this is the underlying physiological process that happens in the brain during the development of Alzheimer's. And I'm going to show the same slide like Zani showed. We have a very early biomarker. It's the A-beta plaque in the brain, and eventually you get some tau proteins, and then all the other memory, clinical function, etc. So A-beta is really the first biomarker that you can see in the brain. So maybe that's kind of leading question, and why amyloid imaging? Obviously, it's one of the physiological hallmarks, but having a PET tracer actually shows the underlying pathology compared to the clinical diagnosis, where you have all the other type of diagnostics instruments. Amyloid imaging comes in a number of flavors, like already mentioned. We have fluidometamol, florbetaben, and florbetapir, the 3 approved commercial tracers. There's one more coming up quite soon, I think. And of course, an image says more than 1,000 words. but would it not be more efficient with one numeric value? And that was the target for us with this work that we have been doing here. We have PET amyloid quantification. This is what I believe in. I believe that with the right methods, quantification provides fast, robust, and objective assessment of amyloid images. And I believe that it could also strengthen the confidence in the diagnosis that I give as a physician, if I have some numbers to lean on as well, and not just my experience that may vary from physician to physician. Quantification of brain images traditionally involves registration of image into a stereotactic space. We call this spatial normalization, in order to apply a region atlas, and then we compare the region statistics to some reference database. But in amyloid, we have a challenge. Positive and negative stance appear very different, and that is challenging for spatial normalization, especially if you don't have access to the MR image or a CT image with anatomical information. So due to this challenge, we developed a new type of spatial normalization using a principal component derived adaptive template that could help drive the registration without depending on the MR or CT image. And we generated principal component templates for all the commercial tracers. We're going to have a look at what the principal components look like. And this is the first principal component. And however we sort of came up with this image and the second component, you can read all about it in the published work that we have done around this, but I don't have time to go into the details here. But moving on, we have third component, fourth component, and you can see that the higher number of the higher component number, the less information you have. So sorry, wrong button. The two first components is the ones that I find very interesting. The first one looks very much like the average image. If you have a set of patients that range from negative to positive. And the second component is really where the changes take place when you go from negative to positive. And what we did was that we created a linear combination of those two principal components. And having those two components, we could combine them first by subtracting and then gradually add from the second component to the first one. And by that, we could sort of simulate the whole range of amyloid from negative to positive uptake. So we have a template, but then what we had to incorporate this into our registration processing. And what is novel with our method is that we simply add the weighting factor of the second component into the spatial normalization, just like any other parameter to optimize translation, rotation, scaling, skewing, deforming. We added this one as a non-spatial parameter to be optimized. And that actually helped the registration to drive the patient image into a template that itself changed during the registration. So that, for example, here we have a positive study. That means that the template takes the shape of a more and more positive looking template. So we wanted to study this weighting factor a little bit more. So we created a large scale study where we included 1,121 patients. And this is data from the Biofinder 1 and ADNI. We included data from florbetaben, florbetapir, and flutometamol, as well as, and these patients also had tau imaging, they have histopathology, they have CSF data, and we had the clinical data. So we pretty much had everything we needed to evaluate whether this weighting factor itself, if it actually contributed to the clinical diagnosis, just one weighting factor. And it did very much. We had super good agreement with SCVR, the standard uptake value ratios, the traditional quantification of cortical uptake. We had good agreement with the the pathology. This is the Bischewski staining. So this is histopathology. It's actually better than the traditional. Well, it's very small difference, but it was better than the SCVR values. So by this we kind of proved, and this was November last year. We had this published in Neurology, and I think it proves that the A-beta index itself has a clinical value. And having pathology data as well, it's considered to be class 3 evidence. So with the A-beta accumulation index, we just have one number, and it takes around 15-20 seconds to calculate this number. It doesn't require any region atlas. It doesn't require any reference region. So if you are doing amyloid scanning, you have a lot of debate whether it should be the cerebellum or the pons to be used as a reference region. No reference region in this method. And it doesn't require any subjective interpretation. And we believe that it's suitable for both clinical routine and large-scale clinical trials. So for example, if you want to monitor a patient during a clinical trial, pre-post administration of a drug, a disease-modifying drug or something like that, and you can really measure the changes over time with just one number. The next step for us is to transfer the A-beta index into the centiloid scale, which is a scale that ranges between 0 and 100, but may extend those limits. But the centiloid scale is becoming more and more established within amyloid imaging, and cutoffs are very important to have, and the centiloid scale offers values for cutoffs where you're positive or considered negative, etc. So that is the next step, and then we're no longer depending on which commercial tracer you use. You can still have a value that you can compare. And there was a lot of people involved in this. We had Uppsala University, Lund University, Karolinska Institute, GE Healthcare, Life Molecular Imaging that supported in the development of this method, as well during the studies to evaluate the A-beta index. So, can I try this at home? Yes, you can, or at work, of course. And the cool thing is that it's actually free of charge, free for research. Because Hermes Medical Solution has decided to make their image processing, neurology image processing, available for the research communities. So we have packaged our neurology toolkit into a software that you, in a very near future, can download. For now, you have to reach out to me or your sales representative or application specialist if you're interested in this. So the neurology toolkit is, for now, a command line based tool for neurology, support a nifty file format, which makes kind of limited when it comes to clinical work, but it's not supposed to do clinical work. This is for research. It runs on Windows, preferably on Intel CPUs for the best performance. It's free for research. And if you're going to use it for commercial use, then you have to contact your sales representative. But it doesn't require any license or hasp key or anything like that. So once you have the executable, you will be able to start working and testing this. The first version that we released, I think 2 or 3 weeks ago, actually focused on the amyloid registration and quantification. So it provides you with rigid registration if you have the MR and you want to bring that along into the template space. It offers a fine registration, amyloid registration, the PCA-based one that we just had a look at. It includes the A-beta index if you would like to explore it. It includes intensity normalization, BOI statistics, as well as region atlas statistics. So if you have a region atlas in the nifty file format, such as the Harvard-Oxford Atlas or any other freely available atlas in nifty file format, you can use that with this toolkit. Later, we're planning to include more support for more tracers like FDG, DAT-scan, and also tau imaging is coming up on the horizon. We're going to include more image processing in this package, such as logic operations, mathematical operations, masking, resampling of images, really to make this your complete neurology toolkit for research. And in the future, which is always bright, but I hope it will be something like the end of the year at least, we are going to add support for Atlas region databases and voxel-based databases, which allows you to create your own reference material. So if you have a novel tracer that is not yet available in clinical routine and you want to explore it, I had a customer here working with PE21 and a dopamine transporter tracer. They wanted to create their own database. They would be able to use this tool to create their own database and make their own quantification for research. And my vision with this NTK and the company's idea of this NTK is really to let users perform research, explore the registration and quantification methods that we can offer in our commercial software free of charge, be able to upload databases that you generate. If you have a tracer that is being under development, or perhaps you want to develop your own DATScan reference database for some reason, and you want to share that with your colleagues, or you want to publish your own reference database on a novel tracer, then you should be able to upload that to the cloud or a old school web portal, and allow your colleagues to download it to further explore and use with the NTK toolkit. And of course, we're gonna work with pharma companies on this one. We already have Life Molecular Imaging and GE Healthcare exploring the tools, and hopefully the pharma companies are interested in exploring the same tools as the research community. And in the long run, BRAS will be migrated into from Hybrid Viewer into the Affinity Viewer. And when we do that, we're going to allow you to drag and drop your databases generated with NTK to be able to use them in a user-friendly interface that you get provided with the Affinity Viewer. So how do you access the NTK if you are sort of interested in trying it out? Well, easiest, you drop me an email, or you contact Steve Bloomer, or you contact Helena, and we will make sure that you get a personal demonstration and a crash course in how to use it and get started with this small toolkit. I hope I didn't exceed my time, talking very, very fast. Thank you for listening.
That was fine. That's fine. Thank you very much there, Johan, for a great overview of the developments in Hermes. Helena, do you want to take a question session? Because I see there are some questions listed in the chat and in the question window.
Yeah, really great talk, Johan. Thank you. I love that bit where it shows, I mean, there's so much exciting material in this, I think, for neurology research. I think it's really great that Hermes are going to make this available for free for research. This is a pretty new thing, so it's quite exciting that we'll be doing that. And yeah, I think that movie that you show where it goes from the normal to the abnormal and all the stages, and the fact that weighting factor that we use for the registration actually correlates with the clinical condition of the patient is amazing. I think it's a really nice bit of research. And that PCA registration is currently available in BRAS. So if you a customer have with amyloid BRAS, it will already be there for you if you have the latest version.
Yes.
But the factor is not yet shown in the UI of BRAS.
Right. So the paper in neurology that we had last year in November was really the clinical evaluation of the method. So before that, we didn't want to expose the factor in the user interface, as we didn't know whether we could trust it or not. But I would say that yes, we can certainly trust it now.
Definitely. Okay, I'm going to get a couple of questions. So one question here, we've got Daniel Darian, who I think he's at Birmingham now, but he did used to work with Zani at Imperial, and he was also on Zani's paper about the quantitation of amyloid with the old BRAS software. Daniel asks, can you look at regional amyloid beta load to assess disease progression and attempt to stage disease?
So the A-beta index is a global index, so there will only be one index per brain. For a regional statistics, you still have to rely on an atlas, region atlas.
Okay, great. But I think what you were saying was that you would, in the NTK anyway, or in fact in BRAS as well, you would still have the region map. So you still get the same Z scores that you're used to as the usual BRAS report, but results rather. But then you'd also have this global index, which represents the weighting factor applied during the registration. That's sort of a mix between the normal and abnormal templates.
Right. So the first version that we have released with NTK allows you to intensity normalize images. It allows you to calculate region statistics using an atlas region if you have one accessible. We of course can provide you with the ones that we have at hand. So all the traditional quantification is already part of NTK, the first version. But on top of that, we also provide you with the A-beta index.
Great. Got a couple of things with the chat. So Zani asks, could somebody send him the amyloid beta paper? I think your recent one in neurology. Yes, we can do that. We can do that afterwards, Zani. Daniel McGowan says that he's pleased and glad that this is released. So that's good news. And Zani says, good work, Hermes. So yeah, some good reactions there. Thank you, everybody.
Thank you very much.
I think that's it for the questions. I can't see any more, Steve. Can you?
No, I can't see any in the window at the moment. So thanks to everybody for attending this morning, and also thanks especially to the presenters. We're going to have a break for a virtual lunch again. Now we're going to leave the session running as we've done before, and we shall reconvene at 2 o'clock. So get our time back on track. So thanks again, and see you all at 2 o'clock.